Picture this. A 68-year-old walks into your clinic. Stage 4 chronic kidney disease, type 2 diabetes, previous stent. He is on a handful of pills and doing okay. But his cardiovascular risk is sky high, and you have read about low-dose rivaroxaban for vascular protection, the COMPASS trial. You wonder, should you add it? Today's first story tells you exactly what happens when you do. Good morning. It is Tuesday, the 28th of July. 5 stories today, including a practice-changing negative trial from the George Institute, a sepsis resuscitation verdict from anaesthetics, and the biggest ever look at induction of labor methods. Let us get into it. Story 1. Track. Rivaroxaban for cardiovascular protection in advanced kidney disease. This is the paper that answers a question every GP faces. Your CKD patients carry the highest cardiovascular risk of any population you see. And they have been systematically excluded from every major antithrombotic trial. COMPASS showed rivaroxaban plus aspirin reduced events in stable vascular disease, but excluded anyone with an eGFR below 15. Voyager-PAD did the same for peripheral artery disease. You have been flying blind. Track, published in JAMA in June, is the first placebo-controlled trial to test low-dose rivaroxaban specifically in stage 4 or 5 CKD, including dialysis patients. Led by Sunil Badvi and Vlado Perkovic from the George Institute, it randomized nearly 1,500 patients across 90 centers in 12 countries. Patients got either 2.5 milligrams of rivaroxaban twice daily or placebo, on top of standard care. The result? Zero cardiovascular benefit. The composite outcome, cardiovascular death, heart attack, stroke, or a peripheral artery event, happened in about 22% of the rivaroxaban group and 21% of placebo. Statistically identical. But here is the catch. Major bleeding was significantly higher with rivaroxaban, about 9% versus 6%. So you are accepting real bleeding risk for zero protection. The trial was stopped early by the Data Safety Monitoring Board for futility. That is worth noting, but the confidence interval rules out any meaningful benefit. The population was also more primary prevention than you might expect. Only about 19% had established coronary disease. Think ASCEND and ASPREE, the aspirin primary prevention trials that showed the same pattern, no benefit, more bleeding. Why did it fail? The uremic vasculature is different. The platelets in advanced CKD are already dysfunctional. Adding anticoagulation does not tip the balance toward protection, it just adds bleeding. And the population was enriched with patients whose only risk factor was age or diabetes, a group where even aspirin struggles to show net benefit, as ASPRE showed us right here in Australia. The bottom line. Do not add low-dose rivaroxaban for cardiovascular protection in your advanced CKD or dialysis patients. This is a clear, clean negative. For secondary prevention, aspirin stands. For primary prevention in advanced CKD, the answer from track is, leave it alone. The kidney community has been waiting for a dedicated trial in this population for years. Track is the first, and it says no. Story 2. Arise fluids. The sepsis resuscitation debate is settled. Now shift gears. You are the doctor in a rural ED at 2 in the morning. A patient rolls in with septic shock. You give antibiotics, you give a liter of crystalloid, and then what? Push more fluid, or start noradrenaline early. Arise fluids, published in the New England Journal in June, is the Australian and New Zealand answer. From the ANZICS Clinical Trials Group and the ACEM Clinical Trials Network, it randomized 1,000 patients presenting to emergency departments across Australia and New Zealand with septic shock. One group got restricted fluids with early vasopressors. The other got liberal fluids with later vasopressors. The primary outcome was days alive and out of hospital at 90 days. The result? Identical. 76 days in both arms. No difference in mortality, no difference in any secondary outcome. Except one. Pulmonary edema was 8 times more common in the liberal fluid group, 5% versus less than 1%. This is the third major trial to converge on the same answer. Classic in European ICUs, Clovers in American emergency departments, now Arise fluids in ours. 3 continents, over 3,600 patients, all saying the same thing. After your initial 1 to 2 liters of crystalloid, either strategy is defensible. The Surviving Sepsis campaign still says give 30 mL per kilo, but that recommendation carries low certainty evidence and is softening with each iteration. There is one nuance worth highlighting. Arise fluids was an ED-based trial, not ICU. The intervention ran for at least 6 hours and up to 24. So the evidence speaks to the window where you are actively resuscitating in the emergency department or early ICU admission. Once the patient is stabilized on the ward, it is back to usual care. And importantly, both arms received an initial crystalloid load before randomization. Nobody is saying skip the first liter. The debate is about what comes after. The practical message for your rural ED. Give your initial bolus, then individualize. If the patient is drowning, pull back on fluids and reach for the noradrenaline earlier. If they are clearly underfilled, you have license to give more. The era of rigid dogma in sepsis fluid resuscitation is over. Treat the patient in front of you. Story 3. The O&G Corner. The biggest ever look at induction of labor methods. This one is for talking to your wife about tonight. The Cochrane Network meta-analysis on induction of labor, published this year, is the largest synthesis ever attempted. 106 trials, over 30,000 women, from 35 countries, comparing 13 different induction methods side by side. The question is straightforward. Which method gets you the safest vaginal delivery? The headline may surprise you. No single method was clearly better than low-dose vaginal misoprostol for the outcomes that matter most. Achieving vaginal delivery within 24 hours. Caesarean for fetal distress. Perinatal death. Vaginal misoprostol at 50 micrograms or less is effective. But there is a safety signal worth knowing. Mechanical methods, balloon catheters and osmotic dilators, plus oral misoprostol at low dose, all reduce the risk of uterine hyperstimulation with fetal heart rate changes, compared to vaginal misoprostol. So if you are worried about tachysystole, especially in a scarred uterus or a high-risk pregnancy, a balloon catheter or oral misoprostol is the safer play. Same effectiveness, less hyperstimulation. A separate individual participant data meta-analysis, also published this year, looked at combining balloon catheter with concurrent low-dose vaginal misoprostol versus misoprostol alone. Vaginal delivery rates were the same. But the combination had significantly less hyperstimulation and less meconium-stained liquor. The caveat: the evidence quality was low because many of the underlying trials failed trustworthiness checks. The authors were careful about this. The practical takeaway: the method matters less for achieving delivery than for safety profile. Vaginal misoprostol works, but carries more hyperstimulation risk. Mechanical methods and oral misoprostol are safer alternatives when uterine overstimulation is a concern. Good discussion point for the labor ward. Story 4. Overlord MS, rituximab matches acrolizumab at a fraction of the cost. You may not manage MS directly, but you refer these patients, and the neurologist will be talking about this trial. Overlord MS, published in the New England Journal in July, is the first randomized head-to-head trial of rituximab versus acrolizumab in relapsing MS conducted across 12 neurology departments in Norway and Sweden. 218 adults with newly diagnosed relapsing MS were randomized 3-2. The primary endpoint was the absence of new or enlarging MRI lesions between month 6 and 24. Rituximab was non-inferior. Over 92% of rituximab patients had no new lesions, compared to about 95% on acrolizumab. The difference was under 3 percentage points, comfortably within the pre-specified non-inferiority margin. Relapse rates, disability progression, and cognitive outcomes were similar. Serious adverse events were the same, around 7 to 8% in both groups. Though rituximab had more infections overall, 82% versus 69%, most were minor. The kicker is price. A year of rituximab costs roughly 1/6 of acrolizumab. In Australia, acrolizumab is PBS listed, so the patient does not feel the difference. But the health system does. And the WHO added rituximab to its essential medicines list for MS in 2023, specifically on the strength of its access profile. For your referrals, acrolizumab still holds the primary progressive MS indication, the pediatric license, and the regulatory certainty. But for newly diagnosed relapsing MS, rituximab is a highly effective, dramatically cheaper option where off-label prescribing is acceptable. This trial removes the assumption that paying 6 times more buys better outcomes. In resource-limited settings, and increasingly in publicly funded systems, that matters enormously. Quick hits. First, a brief GP intervention for PTSD symptoms after critical illness. The PICTURE trial, from Munich, published in the European Journal of General Practice. Over 300 ICU survivors with moderate PTSD symptoms were randomized to a brief GP-delivered narrative exposure intervention, or enhanced usual care. Quality of life scores improved at 12 months, with about a quarter of the benefit mediated through PTSD symptom reduction. Why this matters? ICU survivors walk through your door with unrecognized psychological morbidity. A structured conversation, not a specialist referral, can make a real difference. Second, post-reperfusion blood pressure in acute stroke. A post-hoc analysis of the BASS trial, published in Clinical Neurology and Neurosurg, looked at over 1,200 patients who received reperfusion therapy. Each 10 mm mercury rise in mean arterial pressure in the 24 hours after reperfusion was associated with worse functional outcomes at 90 days. The takeaway: aggressive blood pressure control after reperfusion matters. Pushing pressures up may not be as protective as we once assumed. Recap. Track. Do not add rivaroxaban for cardiovascular protection in advanced CKD. No benefit, more bleeding. George Institute, JAMA. Arise fluids. After your initial sepsis bolus, either restricted fluids with early vasopressors or liberal fluids with later vasopressors is fine. Watch for pulmonary edema with the liberal approach. ANZIX, New England Journal. Cochrane induction of labor. No method beats low-dose vaginal misoprostol for effectiveness, but mechanical methods and oral misoprostol are safer for hyperstimulation. Tell your wife. Overlord MS, rituximab non-inferior to acrolizumab at 1/6 the cost. A cost-saving earthquake for MS therapy. Quick hits. GP-delivered PTSD intervention works for ICU survivors. And keep post-reperfusion blood pressure tight after stroke. See you tomorrow morning. Stay sharp.